Well, hello everybody. Welcome to this week's Infection Control Matters. It's Martin Kiernan and I'm here in, where are we? Oh yeah, Melbourne, yes, with Phil Russo. Hi Phil.
Martin, good to see you back in the land down under.
Yes, I've had a really good time here. Been here a week. I've just listened to you talk about your favourite topic, which is surveillance and the potential and things going forward, really. And I've had a stab at surveillance in the past, and it's incredibly labour-intensive because, of course, it wasn't automated and we didn't have any access to electronic patient records where I was working. And so it was all shoe leather epidemiology. You know. Where do you think we're going with it now? Because there's people talking about automated surveillance, AI, all this sort of stuff. None of it's perfect yet, but I can see it being the future. I can't see it not being the future, to be honest. It has to be, really. What's your feeling about it?
Yeah, look, my surveillance experience is similar to yours, Martin. Lots of walking up and down the corridors, arriving at wards, looking for patients' records that weren't there because they were downstairs getting an X-ray, and so you'd have to come back another time to extract the data from the patient record, and then you go to OR and get the list of patients who've had that procedure. It was a busy time. Well, there was a lot of effort for not huge amounts of return. But, that was the early days of my surveillance career. I'm somewhat envious that I'm not in the clinical areas now.
I really am. Yeah.
With surveillance, because I get really excited about the prospects and the potentials that the electronic medical record is bringing with it. And, flippantly say that it's a researcher's dream because access to data is going to be, well, the potential's huge.
I suppose as long as the data going in is good, because there's a garbage in, garbage out thing.
And that's always the case, and that's the problem with doing retrospective surveillance. Often is you're relying on the quality of the data, and this would be the same with the electronic medical records. And, I hear stories all the time. The electronic medical records in Australia is at various stages. Some hospitals haven't quite got onto them yet. Some hospitals are fully electronic, so to speak. But I'm also hearing there's lots of resistance from clinicians as well with electronic medical records, but I suspect that's an issue to do with change more than anything else. So I think eventually we'll get there, and then once we get there, I think the prospects for research are huge.
Yeah, and for actually interventions, because it's really labour-intensive doing surveillance. And so you end up focusing on a small niche. And you put up a slide, but this is what we do now. But look what we're missing, which is actually probably 90+% of all the procedures we're doing. Yeah. We're not doing anything on that.
Yeah, that's right. And look, that was what we found when we did the point prevalence survey of 19 hospitals about 4 years ago it was now. Strangely or acutely, we identified 100 surgical site infections in that patient population, and of the 100 surgical site infections, only 14 of them were from procedures that would normally come under routine surveillance programs, hips, knees, CAGs, that sort of stuff. There was a whole bunch of 85% of procedures aren't normally part of the routine surgical surveillance, and so they would have been missed had it not been for our point prevalence survey. So I think there's the routine surveillance programs are good and we should be doing them efficiently, but we also probably need to look outside those routine areas as well, and that's where I think point prevalence surveys can have a really big impact.
Yeah, I mean, even if you don't completely trust automated surveillance, it does give you a really good indicator of where to go with it, doesn't it? So if you were focusing, say, on your coronary artery bypass graft or your hips and doing the in-depth stuff on that, but actually if you had an automated system that flags up potential infections in all of the others, it might give you ideas of where to go and target with some more focused surveillance if you didn't trust the semi-automated surveillance. I mean, I'm not sure anybody's ready for fully automated surveillance yet, because that takes out any clinical involvement at all.
Yes.
I mean, you'll get consistency, because, as you said, put 10 infection preventionists in the room and say, is this an infection? You'll get 18 different answers.
Yes.
So that's a tricky bit of it. But do you think there's a potential then to just run two systems in parallel? Or
Yeah, well, look, I think there is. And Mikey Van Murick has mentioned this sort of concept a number of times, is that the surveillance data that the infection control staff isn't necessarily going to lend itself well for national reporting, so to speak, or for public reporting of data. So they want data, clinicians want data quickly, something they can act on straight away. The big picture people, the state people, the national people, they're not so fussed about them having to act straight away. They just want comparable data, reliable data in a uniform method, so you can actually get the bigger picture and see where issues are around the country. So I think you probably will need to have different types of surveillance definitions potentially, or activities for the different purposes. So you could do automated surveillance for public reporting, because then you know every hospital's doing the same thing, but you could have semi-automated surveillance for the hospital level
because
surveillance activities.
If you're doing semi-automated, it would depend on each person's system. So you've either all got to have exactly the same system so you get some consistency, or it's not going to work. But it does work for, this is maybe an issue in this area, maybe we go and talk to the clinicians, and are they seeing what we're seeing, and on the front line, and maybe not picking it up, because if you've got 10 different surgeons in a particular category, they may not be saying many cases each, but actually in bulk you might be seeing a lot, and there may be some common factor in their surgery, like a piece of kit they're using, like the heater cooler units in that may trigger some thoughts. So because I've always thought surveillance is information for action, and I've seen many times surveillance done, like the HAP stuff done internationally. It always shows HAP as the biggest healthcare associated infection, and there's zippo action.
We don't do much about it.
No, that's right. I mean, there's a groundswell at grassroots level, but still no national work going on that. So.
Look, I think the ideal surveillance program allows you to really focus in on those areas where you think there's big issues, or they cost a lot, the outcomes can be devastating, but you also need one that can sort of helicopter up above at a higher level and see the bigger picture as well, and then you can focus back down on those areas that you're in. So I think I really like the idea of doing point prevalence surveys every couple of years maybe, and see what's happening, because I think you'd be surprised at what you find in your hospital.
Yeah. I mean, and also actually, if you're using semi-automated to flag up areas of interest, it'll also give you an indication where you don't need to worry about. Whereas you could actually spend quite a lot of time doing some in-depth work in an area to find out you don't have a problem. Therefore, what was the point of that? So it might focus activity. But then I can see things really changing, because if we switch eventually to all semi-automated, possibly in the future we may go to fully automated, but it then changes what you're doing as an infection prevention team, doesn't it? You switch to being interventionists rather than surveillance specialists, because everything's getting flagged up to you anyway. So then you're going to be doing deep dive into practice to work out why you've got big numbers in that area, and why maybe there are differences between surgeons. And there's big elephants in that room, like the surgical approach. That's never mentioned in any study. You talk about hip replacement, but actually there's 10 different orthopedic surgeons would have 10 different techniques for doing it. So is there a particular technique which is better than others? I don't know. But you would get freed up to do that, to do deep dives, I think.
That's the theory. 40% of IPC's time is spent doing surveillance. If we were able to reduce that down to 5% of time, then the assumption is that they use that gap, then that time, to do the interventions. But I suspect it might get caught up doing other things as well. Or
even education.
You could do broader surveillance activity.
Or the management might go, actually, I need half as many of you now.
Well,
which could be a concern.
That's potential too.
I think that it would be incumbent on you then to say, okay, we're not having to spend so much time on that, but look at the activity now we're doing that actually reduces infections, which is saving you money. So you would really have to work very hard on that aspect, I think.
Well, I think what you would do, what I would be thinking of doing is you do a point prevalence survey. Say, we've got these routine activities nailed down in our algorithm with surveillance activities, but the point prevalence survey identified all these other infections that we don't normally find, and so that's where perhaps we focus our attention in the future.
I mean, you're not really mentioning point prevalence surveys very much, Phil. I mean, I take it you're a bit... It can be quite labour intensive. So if you were recommending a hospital to do one, what sort of period? Talking pick a big day and we're going to blitz everywhere, or how would you go about that?
Look, there's a number of ways you can do it, and it really depends on your hospital. I think if what we found when we did a few years back, I keep keep on referencing it. But the hospitals that had electronic medical records, we were able to do in a day, and they were big hospitals.
Okay.
Hospitals that had paper records, then they take a few days. So if you've got an electronically adapted hospital, then it's not easy. It's never easy, but it's quicker to do. You'd be able to do a point prevalence survey much quicker than you could if you didn't have that electronic medical record. So, you'd be surprised at what you find.
Yeah,
and we have all the methodology done for us. The ECDC protocol is tried and proven. It's now been expanded to include COVID. We're undertaking an activity, a point prevalence survey in the Philippines coming up shortly, working with WHO, and we'd be hoping to find some really useful information over that as well. So it's an area that routine surveillance, longitudinal surveillance is resource intensive. It takes a lot of effort, whereas a point prevalence survey doesn't give you that detailed information, but it gives you a lot of big picture information.
Yeah, and maybe where to target activity.
That's right. Yeah.
What about going forward in AI now? I mean, I've seen plenty of papers suggesting that AI is very good at detecting cancers on X-rays that aren't, the human eye don't necessarily pick up that well. And somebody was reviewing it. You're going to get fatigue, I would think. And you hear stories of things being slipped through. Could it be picking up infections or will it? Can we get predictive work doing? I heard Erica Shea saying that they've got some machine learning there that predicts C. diff infection in patients pretty reliably. Yeah. So then you start flagging up to people, okay, you need to be really careful about what antibiotics you're giving this person or expecting. It's almost like a sitting duck indicator, isn't it?
Yeah, yeah. Look, I think the scope for AI is huge in this space with electronic data. A couple of years of historical data to feed the AI machine. It's really exciting. I said during my talk, I can't get my head around AI because it's bigger than my brain. I can't think that far ahead because it just seems to have the potential for anything. Yeah. Good and evil. So hopefully that I have no doubt it will play a big part. And there's probably already work being done out there with AI and surveillance.
I mean, the machine learning aspects are really quite fascinating, and just picking up on things already automatically gathering data that you routinely collect. Yeah. Like in the States, often their ventilator-associated event data. That's all routinely collected anyway. Right. So that's what it is. It's unarguable, and it's not necessarily infection. It could be some other problem related to a ventilator, which is equally worth picking up as well. So, the more we can integrate our systems, the better our data is going to be. That's right. And actually using AI, you actually don't have to have interfaces that talk to each other because they can just extract directly. Because one thing I had, for example, an issue with in the UK is I had a surveillance system, but it cost you a fortune for an interface to the patient administration system, it cost you a fortune for an interface into the theatre system, and again for the pharmacy system. So you're having to pay these companies for all the different interfaces, whereas if you've got an AI machine there that's actually just taking a normal extract, which you can get out of any of these databases, and combine them together, it's probably going to be pretty cost effective as well, really. Yeah.
What I would like AI to also do, and it probably will be able to, is to identify those patients who are at a high risk, but also tailor-make interventions to the specific patient. So, this patient's got particular risk factors, and so the intervention or the preventative intervention for them is different to the patient next door who's got slightly different risk factors. So rather than just doing the blanket prevention intervention for everybody, you can actually tailor-make your interventions to the patient. I think that's a really exciting option.
Yeah, I mean, and also actually using other data we don't routinely use to actually predict an area that may be about to have an outbreak because their alcohol hand rub consumption has dropped, or there's aspects like that. Their PPE use has changed, although actually we're trying to get people to change PPE use anyway and trying to decrease it. But there will be some things, some triggers out there that almost warn you something's going to happen. Yeah. I know Mark Garvey in Birmingham in the UK reckons he can almost predict which wards are going to have problems because they're alcohol hand rub. Really? They do monitor that. He's not published on it actually, but Mark's got a long list of things to publish. But I think there's lots of potential to draw data from all sorts of sources in an organisation to look at actually what's going on.
Yeah, yeah.
I'm really jealous, I've got to be honest. I went from paper systems, having to flick through paper reports, no computer, no email, which was bliss, And we did actually have a computer that we were giving antibiotic sensitivities back to some drug companies. So I would have to sit there and go through each report and manually put them in. And the surveillance system was me remembering, oh, hang on a minute, we had one that looked a bit like that a few weeks ago.
Yeah.
The sensitivity pattern looked similar. And then you could, after 20 minutes, get it to chuck out some data to say, this looks similar-ish. And then you send them off for typing, and it's like 6 weeks later, not helpful.
Yes.
Whereas, Alex Sinderman and folk like that in the States are doing whole gene sequencing on the whole lot twice a week, and they're spotting outbreaks on case 2.
Yes.
Yeah.
No, I we're starting to sound like old farts, Martin, but
Yeah,
I remember the first surveillance, everything was recorded in an exercise book.
Yeah. T-cards.
There was columns and rows, and
Yeah,
you had to handwrite it.
Yeah.
Patient names and UR numbers and all that sort of stuff. But it's a bit different now, yes.
Yeah.
Yes.
Oh, well, here's to the future, Phil, but
Yes.
not necessarily ours. Okay, thanks very much. Great to speak to you as ever.
Good to see you, Martin.